And we're back. We have Peter O'Sullivan for round two. Peter initially was on with another Peter Kent, talking about their cognitive functional therapy trial and research. Peter, thanks for coming on again. This is going to be a
It's a
much
pleasure.
different conversation. We actually may touch on CFT at some point, but before we dive into what we're going to chat about today, Peter, if people haven't listened to that initial episode, can you just provide a brief intro on yourself?
Oh, yeah. So I kind of wear a couple of hats. I'm a clinician, work a number of days in clinical practice, mainly with people who have pretty much failed interventions with chronic pain. And the other part of my role is I'm a professor at Curtin University, and my main role there is around clinical research into chronic pain problems, and also a bit of teaching as well, which I love.
Yeah, so I saw this tweet we're going to talk about that Elon Musk tweeted 2 weeks ago as of this recording, so early to mid-April of 2024. I definitely don't follow Elon, but I think it was from you or someone else that had to comment on it, and that's how I found it. But since then, there's been a pretty big backlash, at least in this community and rehab field, of some of the thoughts of what the statements of what Elon said. So for people that aren't familiar with the tweet, I'm just going to read it out loud so people are aware and we can dive into it from there.
Yeah.
So Elon Musk tweeted this, quote, "If you're experiencing severe neck or back pain, I recommend looking into a disc replacement. If you do, err on the side of a disc with limited movement. A simple hinge is more likely to be effective than a high quality mobile artificial disc that can translate as well as rotate." End quote. So based off of that, I think there's a lot of concerns that an individual of Elon's stature and prominence and just the sheer amount of people he reaches is making as a recommendation to look into with such confidence. So that's what we're going to dive into today. The concern about this tweet, the evidence or lack thereof on disc replacements, and what should patients and clinicians consider as alternative or primary treatment options. So Peter, maybe we start with initially your understanding or your thoughts on disc replacement, the current kind of body of evidence, and why this tweet was potentially concerning as Elon wrote it.
Yeah, so, look, I'm not an expert in surgery, but Ian Harris would probably be a really good guy to ask about that, because he's published a lot around critique of spinal surgery or surgery itself for managing pain. So amazingly, there are no clinical trial. There's one clinical trial that's compared disc replacement to non-surgical treatment. And that was a Norwegian trial that was published in the BMJ. And there was a 3-year and a 8-year follow-up to that trial. And they showed that there were small statistical differences, but not significant clinical differences supporting disc replacement over non-surgical treatment. So that's one really important thing. The other important thing is it comes with significant risk. So I think they reported, I've got it here, 26 out of 77. So that's nearly half of people had significant complications from the treatment. In fact, one person had their leg amputated from a problem with the surgery. That's really big deal, and it's really expensive as well. And not only that, but there's the aftercare and the time off work and all of the rehab that goes through that process. So that's for back pain. In terms of comparing disc replacement to neck pain, I'm not aware of any clinical trials that have done that. Now, amazingly, we in our health system, we roll out a treatment that is, one, expensive, two, comes with risk. And then there's the whole revision story. Like, this thing is meant to only survive for 10 years. And the complications of trying to replace it, or then you end up doing a fusion. There's a whole story that we don't know about that will be emerging. we know very little about, that will emerge down the track. If you do this in a young person, what happens at 10 years down the track when this thing fails and you need further surgery? And so you're just exposing that person to more and more downstream risk as well. The other question is around more traditional surgery, which is a lumbar fusion versus a disc replacement. And the whole thought around this is very from a biomechanical point of view. It's like, well, if you fuse a level, you're going to put load on the next level and you get this domino effect up through the spine. Where if you put a disc replacement in, it still preserves some movement, and that would be good. Well, in the lumbar spine, there's very little movement anyway at the bottom two levels of the spine, and the evidence would say there's no significant difference between a fusion or a disc replacement. So if you're going to have a procedure done, the guidelines would suggest probably go with the one that doesn't need revision 10 years later. Rather than the one. So it's got this sort of sexy appeal, I think, around, wow, you're still preserving the movement and that's good so that you limit the risk. But there's actually no studies to show that it reduces your risk of, subsequent, degenerative changes or whatever the belief is up the chain. So these are kind of appealing notions that really fit with a very strong biomechanical perspective on pain rather than a research-based perspective.
And part of the issue is Elon didn't really discuss or define what severe neck and back pain is. Is that just acute neck pain or back pain? Is that chronic? Are there progressive neurological deficits? What does that even mean? And there obviously is a time and place for spinal surgery. And maybe before we dive into these primary treatment strategies for neck and spinal pain, what would be the indications of a surgical consultation needs to occur soon because we're seeing XYZ? What would, as a clinician or as a patient, deem a more emergent medical and surgical path?
Yeah, so ironically, I saw a person yesterday who had cervical spine surgery, and that was because she had a staphylococcal infection. She had an infection in her spine, and she was at risk of paralysis, basically. So that required urgent spinal surgery and subsequent treatment of antibiotics and systemic antibiotics. It was that's the serious stuff. So what do we know about the serious conditions we just cannot miss? Unstable fractures from a trauma would be one, where there's potential for neurological compromise. A quarter recliner syndrome, another one, where you've got compression of the sacral nerves. That's affecting the control of the bladder and the bowel and the saddle, sensation in your saddle area. Progressive neurological deficits from nerve compression is another one. So malignancies, these are the things that we know are important. You just don't miss. So infections, malignancies, fractures, unstable fractures, nerve compression, they're the kind of serious pathologies or red flags that we've got to be, as clinicians, be alert to and identify and respond to really quickly, because that's the indication. But that's literally around 1% of the patients that we see. And, depending on your care setting, and the emergency setting, it may be higher, but in a primary care setting, it's very unusual. And so we have to certainly be alert to them. The majority of neck and back pain is not related to those kinds of pathologies. And this is where we get into this really murky area around scanning people for pain. And identifying black discs or degenerate discs, and so we hear these catastrophic kind of messages on a scan that you have a worn out disc, you have arthritis, you have narrowing, you have, fissures or whatever, which of course make people alarmed and worried and make people think that their body is damaged. And so the natural consequence then is, well, I need to fix the damage. Like, you've got a worn out tire in a car, so you need to replace the car tire. The concerning thing around that is, if you look at how predictive those findings are for both current pain and disability and future pain and disability, they're not. And so essentially we're providing a surgical intervention for something that is not predictive of your experience. And that is very rarely explained to patients. That would deeply worry me if I was going to have major surgery to treat something that was not the predictor of my experience. That would greatly concern me.
Well, it is so hard to have that discussion with patients about just how high these base rates of these findings are, and how they really don't strongly correlate with your presentation or your function, and getting that discussion to flow when they've already heard from a surgeon or multiple surgeons or other providers that this is extremely serious and we need to act on it, or you need to be extremely cautious. Trying to have that reversal of narrative or slow transition of beliefs is really tough. For someone like Elon to make this tweet where millions of people are seeing it, that is concerning, because like you said, there's 1% that have these very concerning emergent pathologies and diagnoses. And even within those, is disc replacement the strategy? Probably not.
Exactly.
But what do people think when they read that tweet? There's no nuance as to what are my primary treatment strategies and interventions to receive for severe neck and back pain. So let's move towards that. What would be a better tweet or something that millions of people should hear when they think of severe neck and back pain? Not hearing this recommendation for considering a disc replacement, what are the things that giant population should think of and be informed on?
So we think a lot about this a lot. What are really helpful public health messages? And it's tricky with something around pain because it's so complex and it's so multifactorial. So to get a message that sits well with a broad population is actually quite difficult. Not frightening people, but also alerting people that if the pain, if you've had a trauma, if you're losing power and sensation and you can't pee, then you need to seek urgent medical care, like urgent. So that has to be put in a public health message, but it's only 1%. The majority of back and neck pain disorders, which are really common, are not associated with or predicted by serious pathology. That's really important for people to know. So the majority of cases, and if you think of a population, that means 95% of people sitting out there who experience, and we know that's a really, really common experience of having neck and back pain, and it can be terrible. The majority of those cases, it's not driven by serious pathology. That means, number one, don't panic. It will get better. And for the majority of people, it will get better irrespective of what you do. And so we know that for most acute neck and back pain problems, they will recover, significantly within a couple of weeks, irrespective of what you do. But if they become persistent, if the pain becomes persistent, then we recommend that you seek care. Why? Because persistent pain, and you start thinking about what predicts persistent pain, it's things like you start worrying about your pain, you start fearing your pain, you start becoming distressed with your pain, you start overprotecting your body, you start avoiding things like work and movement and activity and social engagement, and it starts buggering up your life. That's not cool. That's not about your body being damaged. It's about your spinal structures being super sensitized because of this whole interaction around your mind and the body and how it responds to pain. Now, that's the honest story. And so looking at targeted treatments for that will engage helping the person to understand the meaning of the pain in the context of their life, but also guiding them in strategies to get confidence back in their body, learning to relax and move and re-engage in life again. And that's a kind of a journey of recovery that puts the patient in the driver's seat rather than the clinician. The ultimate non-engaged process is being under an anesthetic with being chopped up.
What
So
if
that was a very long tweet. So
well,
I suppose if I was going to do a tweet, it's like, neck and back pain can be really distressing and severe. It's normally not related to pathology, and it will normally get better. And if it doesn't, make sure you find someone who will support you in a journey to your own recovery. Something like that would be my tweet.
for maybe not the devil's advocate, but for the person that said, well, it seemed as if Elon had quite a bit of relief from this.
Yeah.
What are the possible explanations as to if someone was to get a surgery? Obviously, for Elon, we have no clue what his prior medical background was. We don't know what other options he tried, all these other things. But what are some potential explanations as to why someone may have gotten better after a surgery?
So there are lots. In fact, there's a really cool book that Ian Harris wrote called Surgeries, the Ultimate Placebo. If you want to have a look at it, it's worth looking at. And he kind of documents all these placebo blind trials that have been. He talks about bloodletting, like how we used to just cut people and let blood because we thought it was good for their health. And then we realized that actually it was not helpful at all. So we were doing that for years. And he talks about the placebo blind trials. Knee arthroscopy is a great example. It's like, people recover, but if you just anesthetize them and pop 2 little holes in and do nothing, it shows the same course of recovery. So this taps into lots of things. It taps into the narrative of beliefs around pain. If you believe your pain has caused you damage, is caused by damage, and you have an intervention that fixes your damage, you flip your belief. It's like, oh, my body's fixed now. So if my body's fixed, I'm not going to worry about it as much. I'm going to be more confident. I'll be more engaged. I will naturally re-engage in stuff differently. I'll become less pain vigilant. So there's this kind of cognitive and emotional and behavioral probably process that potentially is engaged with some major surgery like that. But you probably don't need surgery to take someone on that journey. It's a very expensive and risky process to take someone on that kind of mind-body journey. But probably they are some of the active processes that are involved when a person gains benefit from that surgery. But, you don't have to look far. I mean, again, Ian Harris has published work on spinal surgery for people in the work comp situation, showing appalling return to work rates of like 80% of people not returning to work, and the majority being on opioids down the track. And, it's not a great result. So the panacea doesn't actually, sadly, work out. I mean, it might have worked out well for Elon, and good on him. That's cool for him and his experience. And someone bagged me out on Twitter, actually, saying, how dare I invalidate his experience? It's like, shit, I wasn't doing that. It's like what Elon does is up to him. That's a different story to him promoting an intervention that comes with significant risk and cost to the individual and to society that has not got a strong evidence base, and that other interventions can be just effective, which are much cheaper without risk, and put the patient in control. That comes down to being responsible, I think.
We had briefly mentioned this before we started recording, but for someone like Elon, who he owns a car, he owns Tesla, he created Tesla, he's an engineer, there's this potential mindset of 100%. Fix the broken piece.
Yeah, 100%.
That's not an uncommon thought for a lot of people, and even within the medical community.
Yeah.
For a patient that has that seemingly logical reasoning of, this is my finding, this is what I need to do to replace it. How do you suggest we change that thought of it's this mechanical car, change this, we should be up and running again?
So it's so hard. It depends on the patient as to how you negotiate that discussion. When it's really hard is when the person's, has very high levels of trust in the person who's given them that message. If the person doesn't have high levels of trust, then it's much easier to have that discussion. The other thing that we do is take the time to hear the narrative of the story, because within the narrative of the story, pain is never linear. pain is always fluctuating and disability is fluctuating, but presumably the structure hasn't changed. And so you can start creating seeds of doubt in terms of the understanding of a patient's pain experience of like, yeah, so I'm hearing like a chap in yesterday, again, another person had spinal surgery, and, he's had the surgery and he still has chronic and disabling pain. So we have to be honest. I think, one, we have to be honest, but also to explore the patient's own narrative of how it began. And often pain doesn't begin with injury. And so it's like, oh, well, so you're just degenerating. And then through the examination and the story, you realize that actually pain's really modifiable. The person can learn to relax and move, and it reduces their pain, and they start engaging in physical activity, and it relaxing their body, and it reduces their pain. So it starts creating these natural questions for the patient. It's like, oh, how come if my back is that screwed, does it feel so much better when I'm relaxed and moving, and not, when I'm sleeping better and when I'm more positively engaged in my life? So we tease these threads out of a patient's story to plant seeds of doubt around it all just about being a machine. Like, your car engine doesn't come and go. If you've got a broken piece in your car, it's not good one day and bad another day. It's consistently bad. The human body just doesn't work like that. So we're much more like an ecosystem. I often describe a garden to people. If you haven't watered your garden, you haven't cared for it, it's had no sun, it's going to look pretty shabby. And if you start getting so how do you nurture your own garden? Well, the health of the spine needs movement and activity, sleep, good social interactions. It loves that stuff. And when you start seeing it through that lens, it provides all these opportunities for self-management. When you look at it through the lens purely, you're disc-screwed, it makes no sense to self-manage that. And so getting that shift is really tricky. For some, it's like they love it. They want it, they jump on it. Other, it's much harder. Because they often become very frightened of their body as being this damaged and vulnerable structure. But usually their own experience contradicts those beliefs when you start to explore them, and then you start working with the patient. That can massively contradict their own belief system. So their experience actually starts to challenge those beliefs themselves. That's the best way to change someone's mindset.
There's a lot of common belief that if physical therapy, quote unquote, fails, or physio or rehab fails, then surgery is obviously the best option.
Yeah.
And that belief is very common
100%.
in a variety of conditions and pain. Can you just touch on how that, I mean, you have already, but just how that stepwise belief is probably pretty false in a lot of cases?
Yeah, it's such a tricky one. And, we had this, just in Australia, we have this investigative journalist. It's called Four Corners. It's basically investigative journalism. And they had a piece called The Pain Factory. And it was about, like consumers describing, the harms done to them through spinal surgery and nerve implants, etc. And there was a huge pushback in the medical community here in Australia and from the surgeons saying, well, hey, don't blame us. You guys have failed. Like, you physios have done a shitty job. We're not seeing them first up. You've seen them. They've had endless amount of rehab, and we're just the next people who are trying to help them. And so I think there are a few things in that. Number one is, I think a lot of non-surgical treatment is not well targeted to the drivers of a person's pain and disability. And I think, we know there are benefits of engaging in physical activity, but there's lots of low value care in, treating symptoms. And we've often got, and I think as a profession, got ourselves hooked into this business of just treating the symptom, of like giving short-term pain relief, be it through manual therapy or needling or massage or whatever it is, and then kind of topping it up with a few exercises. And, that might be helpful for some, and there's evidence for that. But for the people who fail that, where do they go next? And that's is where, our work has been really interested in looking at creating a bridge. If you're someone who hasn't benefited in primary care, what next? Because the barriers to recovery are not about your disc. The barriers of recovery around, your belief systems, your emotional responses to pain, your behavioral responses to pain, that are influenced by heaps of stuff. Your early life trauma, your social setting, all kinds of things will influence that. That means we need highly skilled clinicians who are probably working within a multi-disc kind of framework to help guide patients who are disabled with pain to address the barriers to recovery that we know, based on good evidence, are out there. And the disc is not the main barrier to recovery. So replacing it is just another patch up for that patient that very often, may not work, or it may come with significant risk. So I think I kind of look at it as, failing one treatment doesn't mean another treatment works. It just means maybe we need to reevaluate the care we give people and target that care to what are the key factors for that person.
We had also mentioned this offline, but the conversation, there was a blog or article written about this exact conversation by, I think it was Jordan Strauss. I'm not familiar with him. Is he just a journalist?
No, there was a piece that was led by Giovanni Ferreira that was caught in the conversation. It's a really good piece around the evidence for spinal surgery for neck and back pain. And I can share that with you.
Yeah, that would be great. That is something that we're going to link for people that want to dive generally more into this topic and have some more resources on it.
And it's really helpful to share that with patients as well. Yeah.
Yeah. Do you have any other recommendations for where people can go, ideas of how to try to combat some of these commonly held beliefs and information that's being published?
Yep. So, we try and put a fair bit of this stuff up on our website. Bodylogic.physio is our website, and we have, like the facts and myths of back pain as part of that. We did a series around the facts and myths of back pain as a podcast that's also on that website, and patients have found that helpful. We have infographics that we've developed to try and just give evidence-based information. There are some interesting books out there now as well. So I mentioned Ian Harris's book, Hypocrisy. What is it? There was one written. The Surgery is Placebo is one book, but look for Ian Harris. He's he's a surgeon, and he's a honest and fearless critique of his own profession. Surgery has a really important place around trauma and fractures and dealing with neurological disorders, and like the person I saw yesterday had an infection. Really important. So, we can't be bagging out another profession. It's just when that intervention is not used in an appropriate way for that person, that's a whole different story. So it's like the arthroscopy story. We've got the same thing happening in the spine. So I can send you to some links to some really good books. There's a guy called Liam Mannix who wrote a book recently as well around the whole industry of back pain and what the emerging treatments are that provide hope for people. So, and we've had a number of people contact us who have read that book, consumers who have read that book and gone, hey, this is describing me. That's my story. On the Restore Back Pain website, we have patient stories of people who have suffered from really disabling and distressing pain, talk about their journey of recovery. There's a heaps of great stuff out there. It just doesn't get as much prominence as Elon's tweets, unfortunately. There's another guy in the States called his label was chronic pain champion, I think, and he just wrote a lovely piece around self-management. Tom Bowen, I think, is his name. So there's some really cool work happening out there on from a consumer perspective, from researchers, clinicians who are really here to try and support our community, because pain is such a massive burden in our community. It's a leading cause of disability. It's a huge problem, and we haven't addressed it well, and it's getting worse. So clearly doing more of the same stuff, which we've done for the last, 20, 30, 40 years, is not going to make the problem better. Giving everyone with neck and back pain a disc replacement is not going to take this monstrous problem away. I can promise you that.
Yeah, thank you for mentioning all those, and we'll link all of them. Ian's work is amazing. I actually have Hypocrisy in the other room, and I'm about to start it.
Yeah, it's a great book. That's the one I was thinking. Yeah.
Yeah, I think the first one you mentioned, Surgery, the Ultimate Placebo, Hypocrisy.
They're quite confronting books for patients. I think particularly if they've had the surgery, they can often feel like, shit, won't anyone tell me this? And he often says, look, if you're going to see a surgeon, ask them, what is the evidence for this treatment versus not having it? What are the risks involved? What are the costs involved? What's the downstream? What happens if it goes wrong? What happens at 10 years when this thing needs to be taken out? They are the honest questions that we need to ask people. And, like I had this kind of conversation with a surgeon via LinkedIn, and I said, I hope you're telling your patients that the evidence for a spinal fusion is no better than non-surgical treatment, and same for a disc replacement. But the risks are significant, and the downstream, you're going to be limited in your functional capacity for weeks afterwards. Do you explain those things as a treatment? And it's like, for us, we have to explain, what the risks and benefits are and the costs for what we do. And we should be doing that in health. And often the patient's going, I had no idea. I had no idea that that's what I was in for, or what these were the complications, and what the downstream was. And that's what good care is. It's about shared decision making. It's being open and honest about what the risks and benefits are for the various treatments that we can offer people.
Any other final thoughts on this topic, Peter? I know this was a shorter episode, but I think we hit really all the things I wanted to cover. Do you have any other final thoughts?
I think there's a general pessimism in the community around chronic pain. I think, often as clinicians and as a society, we're like, oh, well, you just got to live with it. And, one of the things that we've found in the Restore trial is that, people who'd had pain for an average 4 years, who are very disabled and distressed, as a group, we saw these significant and sustained large effects for reductions in pain and for disability. And, they're not cured, but often people with pain will tell us that, I still have pain, but I'm living again. And I think we have to be honest with people. Like, we don't have cures for chronic pain, but we have interventions that can help people make sense of it, that can provide pain relief, that can get people back to living again, to get their lives back. That means pain doesn't dictate their life, that pain doesn't rule their life, that it doesn't, set their trajectory. That's the kind of conversation I think we need to be having with patients, because often there's this idea of, I need to cure my pain. And in all reality, I don't know about you, but I feel pain in my body pretty much every day of my life, but it doesn't dictate what I do. It doesn't, it might remind me to be more active or get more sleep or to say no to more podcasts or whatever. But understanding what pain means to us is so important, because we have a general narrative, I think, in our community that, there are no treatments that are effective. And so we just end up reverting to drugs and procedures and implants and, it's often unhelpful, risky, and, just treatments that we don't have a strong evidence base for because we've given up. And I think that's where the narrative needs to change, of like, there is hope for people, but it's not a fix. and it will demand a partnership where the patient themselves learns to take active care for themselves. And that's a switch in terms of how we think around healthcare. But it's a story for any chronic health condition: diabetes, heart disease, mental health, you name it. The pharmacology and surgery hasn't fixed those problems. It's treated the symptoms maybe when they're acute. But self-care is the best care. And our job as practitioners is to help guide people to become proficient in caring for themselves. I think that's the story and the narrative that's honest, that we need to sell to people. And it's a harder sell than a quick tweet on a disc replacement if you've got pain.
Yeah, I 100% agree. I think this is a perfect place to call it. I think people should dive into the resources that, Peter, you discussed, and look at what are the better treatment options, and the realization that this is not a simple solution like you alluded to. And we have to struggle through this with patience and try to navigate the messiness that is pain.
It is,
and living your life with it.
Yeah, and living well. Living well with less pain, maybe not with no pain. For some people, they may report very little pain, but chances are it'll pop up at times when there's a crisis. It just has a habit of doing it.
Yeah. Okay, Peter, we'll call it there. Thank you so much.
Pleasure. Nice to chat.
Of course. All right. Have a good one.